Good afternoon and welcome to this month's show. I'm Luke McCormack. During today's show, we will discuss critical issues facing government and industry leaders in using information technology to improve healthcare and healthcare services. With me on today's show are Mark Vafiades, Senior Advisor, Office of the National Coordinator for Health IT at the Department of Health and Human Services, Jose Arrieta, Chief Information Officer, Department of Health and Human Services, Shermender Paul, Chief Data Officer, Department of Veterans Affairs, Bill Tinston, Program Executive Officer, Defense Healthcare Management Systems, John Harris, Director of Federal Mobility Solutions, Verizon Public Sector, Cara Edwards, ServiceNow Healthcare Solution Consultant, and Ben Cushing, Director of Emerging Technologies at Red Hat. Well, this is certainly a very important subject for a lot of people. It's certainly very timely. We have a great mix of departments and agencies and partners here with us today, and a variety of roles that each of you are holding. So this should be just an absolutely fantastic conversation. Mark, let's start with you. Give us a state of the program that you're involved with there at Health and Human Services.
Thank you, Luke. First of all, one of the things we've been working on for the past few years, and we're really finishing up, and that is the implementation of provisions of the 21st Century Cures Act, which was passed almost unanimously in 2016 and signed into law. And two of the provisions that we're really working on that we think are transformative for the healthcare system are interoperability and patient access. So let me just start real quickly with interoperability. That is the ability for providers and healthcare organizations to share medical record information, healthcare information on their patients with others. And that has not been the case previously. If you're seeing one doctor that isn't necessarily connected in the same organization as another provider, then they're not necessarily sharing information. So you could go to a doctor, you could have some lab tests and so forth, and then go to a second provider, a second doctor, and they're asking you about maybe those lab results because they don't have them. They may even give you a second test, something you had last week, which not only is costly, but it's just a lot of trouble. So again, this will allow and require health organizations and providers to share all your healthcare information with one another. Patient access, that's the second major part of this, and that allows the patients to be in control of their own healthcare information. And the provision requires that there will be application programming interfaces, which basically is the gateway to information on each provider's portal that will allow a smartphone app to go to that portal, collect that information, and bring it back to your smartphone. And those smartphone apps will be for the patients at no charge. So you will be able to see everything that's going on with your health, your lab tests, your conditions, your previous appointments, your after visit summaries, and so forth. So again, this is transformative, and it also kind of puts competition back into the healthcare market, which has been missing for a long time, in that when you see all that information, including pricing information, you'll be able to shop for care.
Wow, that's fantastic, and it sounds like it sounds incredible, and something that every American can certainly enjoy. But it certainly sounds daunting to be able to implement that. Let me go over to Jose, because it sounds like you'll have to get involved with the implementation of something like that, and certainly do it securely, and all these other things that have to be thought about when implementing a system across the country like that.
Yeah, I mean, so first of all, it is an unbelievable goal. I think I'll talk about something that we've built since April 5th. And so as it relates to the coronavirus response, and I think it dovetails nicely into Mark's comments. And one of the challenges we have across the United States in responding to this pandemic is a lack of visibility into and a common operating picture in terms of what's happening on the ground across the US. And so on April 5th, we were given a proof of concept that was a very small proof of concept that was invested in by CDC. And we've gone forth and actually built something that we call HHS Protect. We launched it on April 10th. HHS Protect is focused on protecting people protecting transparency, protecting privacy, protecting security, and finally, protecting integrity and data sharing. The platform itself, by April 28th, we had 2.5 billion data elements in it. We had data that we're receiving data from all 50 states and all 6 territories. We're sharing data with all 50 states and all 6 territories. We currently have about 4 billion data elements in it. The data elements include data directly submitted to us from around 5,800 hospitals across the United States, all of the single sources of truth for case reporting. And we have a diagnostic dashboard, and we have almost all the lab testing that exists across the United States, direct interface, daily feeds into it. And we can look at a common operating picture across the United States as it relates to coronavirus at the federal level, at the state level, at the county level, and at the zip code level. We can get an understanding how the virus itself is impacting different people. Now, our approach, and I'm going to tie it back to kind of what Mark said, our approach has been to actually take commercial technologies, Luke, and instead of hiring an integrator, actually be the integrator and integrate those technologies to deliver the solution. So we have a modern identity access management capability. We have a modern secure file transfer capability. We have a platform that allows for parsing, curation, and sharing with integrity. It's underlined by a hash. It has a time series capability. So when we opened it up to states and one of the states mentioned that we were manipulating numbers, I went back in time through my immutable hash and I said, it looks like you guys actually submitted the same data set twice within 2 minutes and you backdated one of them. Not sure why you did that, but this is immutable. This is the single source of truth. We're running, we overlaid it with mapping technology and ability to sign and agree to digital agreements. We have about 20 DUAs with private sector commercial companies that are providing insights on like the medical distribution network as it relates to coronavirus across the United States. We're running a supervised machine learning capability off the 4 billion data elements to actually predict hotspot outbreaks across the United States so that we can run clinical trials more efficiently, to distribute remdesivir across the United States to help the American people, and to distribute lab testing across the United States. So we put that in place, started on April 10th. The numbers I just gave you is where we are at this time. One of the things that we did recently within the last 2 weeks to kind of get to Mark's point is we actually stood up a public-private key infrastructure. And what we've done is we've created the ability for an organization, like a company, to have a digital identity, government to have a digital identity, an endpoint, whether it's a sensor or a machine, think of an over-the-counter COVID-19 test at CVS, to actually have a digital identity so that we can build an application ecosystem leveraging the data in HHS Protect and leveraging the test results so that an individual consumer can actually keep their test result on their phone, time-stamped, anonymized, in an immutable way, updated at the federal, state level, directly from an over-the-counter CVS test, and then use the data in HHS Protect. So when they're driving down I-95, they can figure out where they should stop to go to the bathroom based on case counts, based on zip codes, based on a live stream API of that data. We think that modernizes the healthcare industry. We think this pandemic in and of itself is a fundamental shift for the industry. Why? We need 1.5 million people are going to have to enroll in clinical trials. We have a clinical registry. We have about 500,000 people signed up. We need people to register for vaccines. We probably going to have to vaccinate 330 million people. If only half of them actually choose to get the vaccination, you've just created a digital identity for 170 million people across the United States and given them the ability to store the record of their vaccination on a mobile device.
Pretty incredible situation there and a daunting task. I love the Lego block sort of approach to building on this environment so that you can provide that capability across the entire country, quite frankly. That's super impressive. Shamender, let's go over to you at VA. You've been over there for a little while now as the Chief Data Officer, and we all know a lot of this is about the data and making sure we have accurate data and making sure we can identify it, index it, et cetera. Give us a state of the status to what's happening over there at VA as you've entered onto the scene.
Thanks, Luke. I will, and appreciate being on the show. And I really want to riff on what Jose and Mark mentioned earlier. Jose is a great partner over at HHS. We're also building a common operating platform, leveraging some of the lessons learned and working out appropriate sharing of data. We report into HHS Protect, our testing. I think all of you know, but maybe the audience may not know, VA runs the largest integrated healthcare system in the United States. So in that role, we're reporting into Protect Now as we're building out a common operating picture to help the executives in headquarters and in the field with the integrated networks, with the medical centers out in the country to better align decision making and support our veterans, and to help us execute our fourth mission of helping to backstop the U.S. healthcare system in this time of pandemic. Also coming back to what Mark was saying about interoperability, access, APIs, aligning with standards-based approaches. We're all in on that, and VA kind of sees ourselves as a key test bed, a key partner for the national coordinator. We've been a leader in doing health information exchanges and things like that. The Blue Button work, for example, started at VA, now is migrated over to CMS. Something I want to highlight, though, is the policy framework. I came in, like you said, about 11 months ago. Been doing a lot of work with partners inside of VA. What's interesting is that CDOs are in all different parts of organizations. Jose is the CIO, he's also the Chief Data Officer. At VA, I'm not in the Office of the Information and Technology. I'm in the Office of Enterprise Integration, which has an internal integrative policy governance function across all of VA. I partner closely with the CTO, Charles Worthington, and somebody in a new role, a Chief Data Technology Officer, Denise Kitts. We work with the CIO, with the executives and the different operating components within VA to drive an integrated data strategy using a data governance council. Some specific examples. I talked about the common operating picture. We're building that to help us improve our response on the COVID-19. Telemedicine is another area. We've been a leader in telemedicine, but over the time of the pandemic, that's just gone off the charts in terms of how much of our service delivery to veterans has been done through telemedicine, tele-ICU, things like that. We're also kind of at the cutting edge of disease modeling. The national surveillance tool. We've developed epidemiological models of COVID-19 and how it manifests. We use natural language processing on the clinical notes in our electronic health record system to be able to generate that signal to allow us to understand the patient journey, inpatient and outpatient, for the veterans we serve predominantly through the Veterans Health Administration. So a variety of different aspects. And, while data has been a strategic asset in VA for some time, the push now is with the Foundations of Evidence-Based Policymaking Act, the Federal Data Strategy, to really take that to the next level. And there's a lot of energy behind,
using the data and the use of this technology, and particularly this modern technology that's being introduced. It's just incredible how we can really attack this pandemic. It's awesome to see this. Bill, how about over at Defense Healthcare? And why don't you give us a minute on sort of, what is the role of, people think about DOD and EHRs there, and then I think about, VA and what they're doing and interfacing, and maybe a quick 101 on what is all that, and then what's your role in implementing all this?
Well, so what we're doing, and actually, I think it was interesting listening to Mark, Jose, and Shamander. It was almost like being at a staff meeting this morning, the topics that they covered. So what we do at PEO DHMS is Defense Healthcare Management Systems, is we're charged with being the DoD provider of health IT. Originally, the new EHR, electronic health record, called MHS Genesis. There's an operational medicine role and a data accessibility role as well. But what's been going on the last year is pretty exciting, and that is taking what we're doing with what in DoD we call MHS Genesis, and working with the VA and working with the Coast Guard, and making it, and going beyond Mark's comments about interoperability, at least within the federal healthcare providers, and making it a common record, not an interoperable record, but a single record, a common record about the patient, not where the care was delivered or who delivered the care. And we're making great progress on that. This month, the Coast Guard goes live with their initial sites, their initial wave. In the very near future, the VA is going to go live, and DoD has 8 sites live at this point, and continue, and has a schedule that takes us through 2023, delivering a modern EHR to the military health system. but it's a single record about the patient and not where the care is delivered. It's very, very exciting. And then the other thing Mark talked about, he talked about access to your own record, but it's more than that from a data perspective. I had another program, it was the operational medicine program, and going through the response to the COVID experience, it has proven to me, and I think this was covered a little bit, or at least touched on by some of the folks before me, but it's not about operational medicine, right? What we viewed in DoD as operational medicine, which is delivering the data about the right patient to the right provider at the right time, based on the characteristics of the care that needs to be delivered and the technical characteristics of the environment. We thought of that as operational medicine. So it gets the common operating picture, right? We all talked about common operating picture. We also have common operating picture efforts underway domestically, but we were able to capture what we were doing with the operational medicine capabilities and bring it domestically and apply it to the COVID situation, and then look at how do we extend this? And as we're looking at this, how do we extend this across non-traditional healthcare delivery environments, the capabilities that we already have, and how do we extend them? So that's what we're doing, and that's telemedicine. Shamander mentioned telemedicine and what the VA has accomplished there. And from a DoD perspective, and this joint federal approach to providing the electronic health record, DoD is leaning into what the VA has done and the success they've achieved there, and trying to adopt the same set of tools to extend the clinical workflows that we create through MHS Genesis to different environments and non-traditional environments.
Absolutely fantastic news there, and I'm sure that every warfighter in the DoD is happy to hear that. John, we can't do this without good connectivity and being able to stitch all this together, telemedicine, et cetera. Where does Verizon public sector fit into an ecosystem like this?
Yeah, thanks again, Luke, for having me. And I think it's a great question. You know, today's environment has put a lot of resiliency and dependency on remote networks. And so, as Verizon, I think we're excited and eager to participate and help to fuel the telehealth and interoperability that some of the folks you've heard talk already have mentioned. So, you know, we're doing a lot of work to expand 5G. I'm sure you've been reading a lot about that recently. But you know, finding ways to provide additional bandwidth, lower latency, and really push new and innovative use cases to our end users. You know, Verizon, we're obviously, you know, concerned today about caring for our employees and certainly, you know, caring for their safety, but then finding ways to leverage technology to innovate and fuel telehealth and keep people maybe out of large healthcare facilities if they need to be isolated and need to be in a safer environment is critical. So recently we just launched our 5G mobile edge compute platform. It's a partnership with AWS. It's called Wavelength. And so finding ways to push compute power to the edge, higher powered you know, applications that can now be delivered outside of a heavy data center. Can really help enable, you know, remote solutions. I wanted to call out Shaminder and his team at the VA. You know, we've been working a lot with folks at Palo Alto on a 5G pilot, where we have partners like Medivis who have been working to really discover and innovate how we can leverage something like 5G to provide better care for patients. So imagine, you know, a world where instead of looking, you know, a doctor looking at a 2D sort of MRI, you know, image on a screen and then trying to turn to a patient and enable or you know, translate that in their mind, you know, where is the issue? What's happening with this patient? Now we can potentially have a VR or AR situation where the doctor can look at the patient and lay the MRI image right on top of the patient and be much more accurate in how we deliver care and services. So, you know, some really, really innovative stuff that's happening, some really, you know, I think exciting things that Verizon can do to help enable a lot of these services at the edge. And that's sort of on the, you know, the cutting edge. We're also doing things just sort of day to day by enabling, you know, mobile EHR access and you know, providing, as Jose mentioned, you know, access to applications when people are up and down I-95 and delivering that information in a secure and reliable way. is critical. So this has presented a lot of new challenges and a lot of new opportunities, and we're excited to leverage the Verizon network and help to deliver for our partners and their missions.
Fantastic, great technology and coming at a very important time. We're going to take a short break and we'll be right back. You're listening to the Federal Executive Forum on the Federal News Network. Welcome back to the Federal Executive Forum on the Federal News Network. We are talking about IT healthcare across the entire country, quite frankly. And I'm going to roll it over to Cara at ServiceNow. And we've heard a lot about different agencies interacting with each other, a lot of telemedicine, et cetera. What's going on at ServiceNow to enable all this?
Sure. So we're working with different healthcare executives and administrators across, the different VISNs. I support the VA, and we're finding that healthcare staff safety and veteran experience is really one of the top concerns and priorities. If we take COVID, for example, the hospital staff members no longer have, working longer hours and are really on the front lines of patient care. So they don't have the luxury of pushing around carts from room to room. They need to be able to push and receive data at their fingertips using their mobile devices or issued devices. So one of our customers over on the private side, they really wanted us to come in and examine, how they can change that patient experience and get the patients to engage more with the hospital staff and find some alternative ways to inject technology. So from the patient perspective, we're entering that digital age where they can order food or request medications or even turn a channel, the room channel on their TV from just using Alexa from their remote. And then on the clinician side, we have, the clinicians that have those issued devices, they can actually stop the blood pressure or temperature machines from beeping. I'm sure you visited someone in the hospital and you hear that annoying beeping in the background. Now they can just use their device to turn that off. Or they can even reassign a task or request from a patient to a nurse that's within that location, just to enhance that patient experience.
Yeah, it sounds like not only the patient experience, but the clinician experience as well, and just a better workflow across the spectrum, which is fantastic. I'm glad to see that that technology has been introduced. Ben, we've been talking about emerging technologies all morning. What's happening at Red Hat, and how do they sort of fit into this emerging technology ecosystem?
Yeah, as already mentioned, COVID-19 has really compounded the existing infrastructure problems in healthcare systems. And patient overflow at a hospital isn't just an issue for resource constraints. The underlying systems also have to scale to meet demand. And the continued adoption of technologies with smaller and smaller footprints has really started to show its value in this time. So allowing for massive scaling events to meet that demand. That same technology is also being used to rapidly build out field hospitals and gyms, parks, and ships for real-time flow of healthcare data. And these small footprints leverage edge technologies, like John mentioned, to produce insights at the site of care, no matter how remote they might be. A fine example can be found with there's a large healthcare provider in I think it's like the Southeast that created a sepsis prediction and optimization therapy platform. It collects and analyzes clinical data and signal caregivers in real time to initiate early sepsis care. They used open source software to create a scalable container-based platform as a service. And the group also uses automation, management, analytics software to support real-time data collection, analysis, and proactive case management. It's really exciting to see that type of technology being applied anywhere, but there are many active programs across the federal healthcare agencies that are using similar approaches. And it's really exciting just to be a part of any of that. Everyone, on this panel and everyone listening are patients, and the broader the adoption of proven innovative technologies, the greater the impact to the quality and duration of our lives.
Certainly, healthcare is important to all of us, our families, our friends, our colleagues, et cetera. And I love the multimodal example that you gave there. Let's get into a specific program that's been super successful. So let's start with you, Bill. Can you give us an example of a program that you all are working on or have already implemented that's really been a success as far as the implementation of healthcare across the community?
Well, I'd rather talk about what we're doing in the sense of a portfolio instead of a program. I sometimes think that we draw arbitrary boundaries around our programs. And so what we're managing at DHMS, and frankly, as we move forward in conjunction with the Coast Guard and the VA, part of the Federal Electronic Health Record Modernization Office, is the delivery of capabilities, IT capabilities to support VA, DoD, and Coast Guard, and potentially other federal healthcare providers across a full spectrum, right? So we put a lot of focus on upfront on getting the electronic health record, MHS Genesis, and the shared implementation with VA and Coast Guard deployed. So DoD has, we started a few years ago. I think we really started back in 2015. We did some initial sites. You may recall there were some observations that it was not perfect at our initial sites. We learned a lot from that.
Sure.
This past September, we went to 4 sites in what we called Wave Travis, which was tremendously successful. So we have 8 sites running. When COVID happened and we all had to look at things differently, what we found, what we observed was, and I talked a little bit about this earlier, is that where we had deployed the modern EHR, that we enabled the healthcare providers to be more adaptable, more resilient, and more responsive to the changing, unknown future needs and changing needs of responding to COVID, new COVID tests, how to order them, things like that. Where we had the new system in place, the new capabilities in place, we were able to make those changes inside a day, actually in less than a half a day, get the updates to training out there, and clinically have people prepared to use them, providers prepared to use them. Where we were dealing with the legacy environments, it took months to get the same thing accomplished. So very exciting. And I talked earlier about how we were able to pull back the operational, pullback's maybe a poor choice, but use the operational medicine technologies that we generally used with deployed forces, right? Think, Afghanistan, people might be using it there. Low bandwidth, and so the 5G and the Verizon talk was very relevant there because we're shifting to all network delivered capabilities and data. But pull those capabilities back. Provide our operational medical situational awareness capabilities to CONUS so that we can get insight into how where beds are, where beds are available, where PPE is, and what the situation is in the military health system and how it all ties together and ties back to the record. And then also take that same set of technology, the operational medicine technologies, and apply it to delivering care in non-traditional environments, right? Going back to the data conversation. We're collecting this data. We have a very rich and very broad collection of data about people, about patients. How do we get that to where the care needs to be delivered? And where care needs to be delivered has shifted. Our whole understanding of that has shifted away from the traditional fixed medical center that people are accustomed to, and we talked about that a little up front, and we need to be more flexible. Because of COVID, and as we go through the COVID, we realize there are other advantages to it, and we're open to creating the capability to do that more broadly.
You got to meet the patients where they are, and I love the example of sort of iterating and learning and evolving is a fantastic example of improving the ecosystem. Cara, let's go over to you at ServiceNow, and you gave an example, or you mentioned that you're working with the VA. Give us a specific example of a program that you've been working on that's been perhaps wildly successful.
So I'll give you one of the things I wanted to share was the fact that we work with the state of Washington, and we're starting to work more with the VA now, but I don't have a specific example for you. But we worked with the state of Washington when COVID first struck, and we built these applications over the course of 3 days. And really it was emergency response and assigning staff and resources to support the emergency, COVID being COVID, distributing information, so emergency outreach, self-reporting so that employees could say, hey, I feel sick, I'm not really ready to return to work, and somehow notifying their managers, of their illness. And then emergency exposure management. So this is where they're identifying and managing exposure risk so that they don't expose their patients or, other staff members. We deployed those applications in March, and then we piggybacked on those applications and built, 6 more so that to release to our customers. And what we found during this time period was our customers wanted, like Jose mentioned, some more dashboards and analytics so that they can track some of the trends and kind of isolate some of those cases. Workplace safety was another application that we rolled out. PPE inventory. We worked with a number of hospitals that were trying to track some of the, PPE equipment that were, you can remember it was just scarce, right? So now doctors and clinicians can check in and check out inventory. In addition to employees that are starting to transition back into the workplace, they can, be assigned, PPE equipment. Contact tracing. We started this, for one of our, private sector companies, and what they wanted to do was try to figure out or pinpoint who was in the meeting rooms together. How can we isolate that group and keep those folks at home so that they do not spread the virus to other members of their team. And then the last application was facilities management. Where do we need to go and sterilize and clean? Which rooms, may have, caused some of this illness to spread? And so we can kind of deploy the crew to go and clean these rooms. So yeah, these applications were built, as I mentioned, over the course of 3 days. And then we had, a Tiger team building these additional applications for other hospitals that we support in the private sector.
Outstanding, real-time accurate information, which is crucial in a situation like this. Sherminder, how about over at VA? Can you give us an example of a specific program you'd like to highlight?
Yeah, I think I want to kind of build on what Bill was talking about. Bill mentioned the FIRM, the Federal Health Electronic Records Management Office. That's a joint DoD-VA construct. It's helping to guide the implementation of the single integrated electronic health record for patients, a patient-centric view. I think by most accounts, this is the largest IT project in government. The partnership with DoD is incredible. A specific aspect that's in my lane is around data management, right? As we go through this transition, whether it's DHA transitioning, whether it's on the VA side, on the VA side in particular, we're going to be dual operations with Vista and the Cerner Millennium for a number of years, right, as we go through the cutover. So it gives us an incredible impetus to dramatically mature our data management capabilities, our data governance capabilities, the tooling and instrumentation we use to support that, how we do requirements management, right, to make sure that we are not missing a beat as we're operating on the VA side, integrated healthcare system, and the same on the DoD side. Related to this, and this is, I think, an important angle on health IT, is this idea of veterans experience, right? Customer experience, veterans experience was mentioned earlier, and every veteran starts out as a service member, right? So it's really the service member's veterans experience as a continuum, and in that lens, we're working really closely with our counterparts in DoD. Me with my counterpart David Spurks, the Chief Data Officer. And then under a construct called the Joint Executive Committee, which is co-chaired by the Deputy Secretary over in VA and the Undersecretary for Personnel and Readiness over in DoD, we're working on a joint data and analytics strategy, building out on this idea of a service member veteran's journey. So you got the electronic health record, but then you got the rest of the story, right? The core identification information, service information, right, to be able to treat the customer as a whole person over their lifetime, right? So that's sort of the vision that we're trying to work towards.
Right, through that entire ecosystem, just like a civilian wants to have, their records go from, doctor to doctor, the same sort of thing. I would imagine that we would want to experience there from service to migrating over to a veteran. John, how about over at Verizon? Can you give us a specific example of a program that you'd like to highlight?
Yeah, I'd love to. I want to build on a little bit of what Sherminder was just talking about around veteran experience. We've worked very closely with the Office of Connected Care over the last couple of years. And, when you think about a veteran, one of the challenges in many cases they have is they live, many, many miles or hours away from, the closest either hospital or clinic location. And so what we have been really working to do is to provide connectivity and remote telehealth solutions to those veterans. And have really worked to deploy, thousands of tablet solutions so that veterans can receive care in their home. They're able to connect back to the VA through the VA Video Connect app. They can have individual session with their clinician, with their doctor. They can connect with other veterans. They can, access many resources across the platform that the VA offers. And so instead of, spending hours in a car or coming into a crowded hospital, they're able to get that health care right in their homes. We've also done some work for folks that maybe don't have access to that tablet-based type solution, and we've eliminated any charges, if you will, for utilization of data on their smartphone. So veterans or anyone really can connect through the application, again, to connect back to the VA, have a video conference with their doctor, and do that without incurring any data charges. So we're really working, I think, to enable these platforms to extend their reach and really leverage the Verizon network to be able to connect folks all across the country and provide that critical care that they need. So some really good partnership with the VA.
That is outstanding. I'm sure every veteran certainly does appreciate that. Let's go over to Mark. Mark, can you give us an example of a program that you'd like to highlight in regards to what's happening over there at HHS?
Sure. We're very lucky at ONC, the Office of the National Coordinator, because we have so many great programs that are under the works. But let me talk about the program for programs, and that is the ONC Tech Lab. And actually, it's at healthit.gov/tech lab. And basically, if people out there in the private sector or the research sector or nonprofits have a project that they're thinking of working on that they think is a really great idea in the healthcare space, they can submit a project. They can do a project submission on that website, and then that way it allows for other organizations to possibly collaborate to make sure there's not a duplication in effort. After all, we are the national coordinator, so this is a way for us to coordinate great projects that are out there. And I'm sure all of you have seen that, with the COVID pandemic, there are all kinds of folks that have said, hey, I've got this really, really great idea for a project that will really help in the COVID space. So we have a place where we can send them to so that they can, again, submit their project and talk about it and collaborate. And if there are other people that are working on something similar, they can collaborate, and it really has had some really great results. We've had over 100 project submissions so far.
Fantastic. Didn't even realize that there was a program like that, and I'm glad there's been such a wide amount of participation. All right, we're going to take another short break, and we'll be right back. You're listening to the Federal Executive Forum on the Federal News Network. Welcome back to the Federal Executive Forum on the Federal News Network. We're talking about IT healthcare across the federal spectrum. We were just talking about specific programs, and I want to throw it over to you, Ben, and give us an example of what Red Hat is up to in regards to a specific program that you'd like to highlight.
Yeah, there's a few. I think I'm the most excited about the work we're doing at DHA right now. We're migrating legacy data systems to modern cloud-based platforms. And we're doing this in collaboration with our partners at several different system integrators using a streaming platform that is actively applying data normalization, cleansing, and then providing a bidirectional longitudinal patient record using FHIR for interoperability standards. Downstream of that platform, we have DHA partners using our AI platform technologies to produce predictive analysis at the population level. That's being proven out right now. And then the next focus is really using that same technology to craft real-time situational awareness of emergent adverse conditions like PTSD, diabetes, et cetera. That state for me is what gets me out of bed in the morning. Really excited.
Fantastic, and super important subject, super important topic, and certainly is very much a real-time situation that we're all facing. Jose, how about at HHS? On your opening, you gave us a lot of examples of different activities that are going on. See if you can narrow down to one specific program that you'd like to highlight where you guys are really going big.
I mean, HHS Protect is the largest public health surveillance system in the history of the United States. It gives us the ability to speed up clinical trials. It gives us the ability to distribute remdesivir. We're using it for that. It gives us the ability to predict outbreaks at every single level across the U.S. I can literally look at the little hospital in the rural location that I grew up with in northeastern Pennsylvania. I can see how many ventilators they have, how many beds they have. I can, how many total beds they have, how many patients have COVID-19, if there's any patients in those hospitals. One of the things that we've done with the data in HHS Protect, and you can see it if you go to protect-people.hhs.gov, we've started to dashboard and share all of the data related to the common operating picture around hospitals. We dashboard the raw data, and then we dashboard estimates so that we can extrapolate that raw data across the entire United States off of the 5,000 hospitals we have every day. And hospital reporting varies every day. That's why the number doesn't stay the same. We've also taken those raw data sets, made them downloadable on healthdata.gov, outlined the steps with which we build our predictive models, and added in policy insights that are occurring at the federal and state level across the United States. So the community of modelers and the community of researchers and the scientists of the future that are at universities can literally work with real-time data across the United States about this pandemic to hone their craft. So when Dr. Fauci and Dr. Birx and Dr. Redfield retire someday, there'll be a community of folks that can carry the baton if an event like this occurs again. We're really proud about that. We're working to partner with associations across the United States to share the data within HHS Protect. We're talking about 4 billion health data elements, federal, state, local, zip code, and county level. We need from a public health surveillance perspective, but we can make it available to associations and companies so that they can lower their fixed costs related to collecting data, or related to whether it's running clinical trials or whether it's informing hospitals as to the environmental activities that are actually occurring around them. Again, it's all built off of HHS Protect. I have to say this, I'm so proud of the OCIO team at HHS. We've lowered our operating expenditures by 12%. Our budget has increased by 170% because of COVID. We've increased our customer service scores by 40%. So now 67% of our customers think we're excellent versus 27%. And we've managed to identify and drive cost avoidance of about $200 million across the portfolio. So all while building the largest public health surveillance system in the history of the United States and working, and I have to thank the Verizon folks for this. And we've dealt with some very large cyber events since March, and we built a modern MTIC to secure the perimeter of HHS, which is one of the largest internets on the face of the earth. And we were able to do that in 120 days at a 74% discount off of commercial pricing. So we have a lot going on. The biggest program is HHS Protect, but I'm really proud of the team. We've done a number of amazing things to be able to.
Incredible amount of work done under such a short amount of time with a lot of constraints. So hats off to everybody over there at HHS. All right, well, we're gonna wrap it up here, and we always like to end with talking about the future. And Ben, we're going to start with you. If you could just paint a picture, sort of look around the corner over the horizon, not too far, but what does it look like out there? What can we expect to see, 3-4 years down the road?
AI is definitely the future for healthcare, right? Most AI today is used for big data analytics. This, of course, affects population health, simulation, value-based care. That being said, I'm really excited about what happens when we use applied AI. My definition of that is AI that actually influences decision-making in real time. Think drug allergy interactions, predictions, things like sepsis, right? Getting AI predictions down to the patient level not just for precision medicine, but to react to adverse emergent conditions as they're happening and maybe even before. We get to that state in a couple different ways. The first is by transforming the IT culture of institutions to align with like Agile and DevSecOps principles. I'm seeing more and more of that inside of the healthcare IT market, and it's really heartening to see that kind of transformation. And then secondly, the use of process automation as a bridge. If you have a care plan defined as a process and that process is actively running in state, then AI can actively influence decision nodes in the care plan. And to do that, we actually have to author those care plans. There's a wonderful initiative going on right now inside of the OMG group, which is the standards body that publishes the standards for business process notation, decision management notation, and case management for like a wide variety of industries, like finance and manufacturing and supply chain. They're now applying those same concepts to healthcare, and they're working with some of the largest healthcare institutions and federal agencies to actually produce models of care plans, and they're calling them shareable clinical care pathways.
That's fantastic. It sounds like some awesome stuff. So, Cara, give us a picture, paint a picture of the future. What does it look like in a couple of years in regards to ServiceNow? What's in the petri dish over there?
Yeah, so what ServiceNow, our plan is to help our IT organizations to really beef up their infrastructure so that if there is another pandemic or emergency situation, IT can better help their customers with providing care or information or data, to make departments a little bit more effective. Just for the VA specifically, we are working tighter with IT and HR so that those common processes or forms, we're digitizing those elements so that really the VA can get back to the mission, which is supporting the veterans and enhancing that veteran experience.
Right. Want to just enable the technology so that they can focus on the veterans. It's fantastic. Glad to hear that. John, how about at Verizon? What does it look like in the future when you fully realize 5G? What does that mean to everybody?
Yeah, it's a huge question, but I think, we like to think about it as though we have really a once in a lifetime opportunity to fuel the next industrial revolution, which is 5G. So, again, pushing technology to the edge. I mentioned earlier the launch of our machine edge compute options to really improve processing power, reduce latency, enable AI, as Ben had mentioned earlier, I think creates an unbelievable landscape of use cases that we really want to partner with industry, with government, with everyone really to try to identify. So I mentioned the work at Palo Alto earlier. I think that's just the tip of the iceberg. With 5G and the platform itself, we have an unlimited future on what we can deliver for healthcare as well as for all of our government and consumer partners. So thanks again for the opportunity, and we're looking forward to building this next industrial revolution on 5G.
Fantastic, and I think we're all looking forward to it as well. And won't hold you to the timeline there, but I'm sure it's coming very, very soon. Bill, how about over at Defense Healthcare? What's the future look like? I mean, what can we expect as a war fighter in 3 years, let's say?
Well, so let me take it up a notch as to what we should be striving for, right? We're a group of IT people here today, so we like to talk about IT. And I think that's powerful, and it helps us drive capability into the hands of the providers and into patient support. But what we really need to be striving for is, and there's a couple analogies I like to use, is IT you don't have to think about, right? Our providers and our patients, or the patients, they don't care about the IT. They care that things work and they get the experience they want. I use a theme park as an analogy for this sometimes to help clarify my thinking. So really, when you go to a theme park, you don't care about the power, how the power gets there, how the plumbing is done, how the roads get there. You care about the rides and the experience when you're in the park. And the IT people are keeping the park running. And from PEO DHMS perspective, we build the rides, which is a really cool thing, but that's what people go to the park for, is those healthcare capabilities that we provide. The other thing that I think is, it's also an analogy, I'm sorry for that, but I read something last summer, not this summer, about about the guy that invented air conditioning, right? His name was Willis Carrier. I think I read it in the Post in July. And it was an interesting story because he was a printer, and he had a problem in his print plant, and he couldn't get the ink to stick to the paper because of the humidity. So he tried to figure out a way to get the humidity out of the print plant so that his print plant would work. And so he did that. He invented air conditioning to do that. He had no idea. He knew why he did it. He had no idea the impact it was going to have on the world, how we work, and frankly, even on healthcare. He knew why he did it. He didn't know where it was going to take us. We talked today a lot about what we're doing and why we're doing it. I think we're in a place now where we're doing the right things, but we're doing things that are so powerful we can't even comprehend where they're going to take us. Much like air conditioning, it did a whole lot more than allow a print plant to operate effectively.
Very good analogy, and really focus on that customer experience. Sharmender, how about at the VA? What's that going to look like in 2 to 3 years?
I'm going to give a CDO-centric answer.
Sure.
I think we're working to further strengthen our identification and management of authoritative data at each of the moments that matter in the service member and veteran's journey, making sure that data is managed, is interoperable, and we're using it to improve operational service delivery. And then second, we have the policy frameworks in place across DoD and VA to use that data appropriately to develop insight, build evidence to improve evidence-based policymaking, and move in the direction of really understanding over the lifetime of our veterans, what's the impact of the services we provide, right? What's the cost, what's the impact, and how on the margin do we improve those outcomes around economic outcomes, health span, or dignity is measured by social connectedness.
Fantastic. Very important, and I applaud everything that you're doing over there. Jose, how about over at Health and Human Services? A lot of stuff on the deck there. What can we expect, around the corner in about 3 years or so?
Yeah, I mean, I think, and I have to agree with what Bill and John kind of couple the items they pointed out. I think that healthcare, I think the reaction to the pandemic has been an investment in data sharing. It has been an investment in ingesting and curating and making data shareable with integrity. I think across the United States, you're going to see a significant increase in investment from in the private sector to develop supervised and unsupervised machine learning capabilities off of open data sets that are going to be made publicly available. Every single morning when I woke up for the first couple months of the pandemic, I'd look out my window, working from the home office, and I'd be like, what in the heck is this guy doing at my door? My wife started ordering groceries and having them delivered. It's fundamentally changed humanity, fundamentally changed the way Americans live. All the money that's not going to restaurants is going to be invested in technology focused on supervised and unsupervised machine learning. Government will become interoperability, data sharing with integrity, and securing those underlying data sets. I think there's a significant change that's going to occur. And don't forget one thing, and I promise to stop, Luke, because I know you're on a timeline. Healthcare is 20% of US GDP on a consumption basis. It's 55% of the United States is 55% of global healthcare GDP. Be ready for some significant changes.
That is a daunting figure there. While we have you here, why don't you give us your top priority for the year?
My number one priority for the remainder of the year is to create and provide full visibility for congressional leaders. We're working on that now. Full visibility for state-level hospital associations across the United States. Automate the interactions with hospitals before the fall if possible, to make it easier to prepare for what Dr. Redfield described in his congressional testimony is the worst fall in American public health history when you combine the flu and COVID-19. So I'm focused on bringing as many capabilities to bear so that we're ready for that moment in time. We can create and provide that visibility. And I do expect a significant amount of tension. Anytime you're transparent with data, it's hard to understand. It's something new. It creates a lot of tension. It creates a lot of discussion. Preparing to deal with that.
Okay, Mark, bring us home. Paint a picture of the future. What does it look like? What can we expect?
Well, the COVID pandemic really emphasized a lot of weaknesses and obsolete practices in the healthcare system, as well as highlighted a lot of strengths and opportunities. One of the opportunities is telehealth. I know that's something that a lot of us have been proponents of, but we've really seen how great it is and how helpful it's been, and that's gonna move forward in the future. There'll be barriers that were up before to telehealth that will be taken down. We're going to try to reduce the clinical burdens caused by electronic health records so that doctors can focus more on their patients rather than on the quote paperwork. And another big advantage of as Jose mentioned, all the data, the healthcare data that's been coming in, is that we'll be able to do with de-identified data, a lot of data mining research. So it's not going to totally replace replace some of the in-person type of research, but people are going to be able to take that de-identified data and really take a cohort of folks and see how different conditions, different medications affect them, and that kind of thing. So it's really, it's a brave new world, and we really have just a lot to be optimistic about regarding that.
The theme is focus on the patient, right? And that's what we've heard throughout the show. Well, I'd like to thank today's guests for taking the time out of their busy schedules to join us for the program. I'd like to thank our sponsors for supporting us on this show. I'd like to thank the good people here at the Federal News Network that make our program so successful and enjoyable. And most of all, we'd like to thank you, the listening audience out there that tune in every month. You're listening to the Federal Executive Forum, part of the Federal News Network.